Okay, let's get right into it. Today, we're taking a deep dive into a joint you use every single day, probably without thinking much about it unless, well, something goes wrong. The knee.
That's right.
On the surface, it just looks like a simple hinge, right? Bending, straightening seems pretty straightforward.
Yeah, it looks that way.
But tucked away inside is this incredibly sophisticated piece of biological engineering. I mean, it's designed to handle just immense forces, complex movements.
Absolutely. Every time you stand up, walk, run, jump your knees, are managing that load, providing stability, enabling all that motion.
And when something does go wrong, as the source material we're using today makes really clear, it can dramatically impact your ability to just, well, live your life normally.
And that's really the core of what we're exploring today. We're diving into a detailed surgical text, the kind of resource professionals rely on to truly understand the knee. From its basic design all the way through to how we fix it when things break down.
Exactly. So our mission today is to guide you, our listener, through that really intricate structure, understand how it functions under all that pressure, explore the most common ways this complex system can fail,
Uh-huh.
and then delve into the detailed world of modern surgical management. We're going deep, using only the insights from this specific source, aiming to build a really robust understanding. The kind of foundational knowledge that feels like you're mastering the topic, much like the professionals in the field.
It's about moving past just a surface level view to really appreciate the engineering marvel that is the knee and the precision required to keep it working or, restore its function when needed.
Perfect. So let's lay that groundwork. The source kicks things off by classifying the knee joint. It calls it a complex synovial hinge joint. Now, synovial just means it's a joint inside a capsule with lubricating fluid, right? Like lots of joints.
Right, that's standard. Hinge suggests that simple bending motion, flexion, and extension.
But as you said, it's more complex. The source immediately adds that crucial nuance. While it functions mainly as a hinge, its actual structure is, well, more involved.
Exactly. It's formed by two distinct articulations. You've got the tibiofemoral joints, that's where the big rounded ends of your femur, your thigh bone.
The condyles.
Yes, the femoral condyles meet the relatively flatter top surface of your tibia, the main shin bone.
Okay.
And then there's the patellofemoral joint, that's where your kneecap, the patella, sits in that groove on the front of the femur and moves along it. The source describes the tibiofemoral joints as condyloid, sort of oval-shaped sockets, and the patellofemoral as sellar, or saddle-shaped.
And these shapes are really important, aren't they? The source points out that this structure, with these curved femoral surfaces meeting the flatter tibia, it makes the knee inherently kind of unstable.
Precisely. It's not like a ball and socket joint, say, in your hip, which has a lot more bony constraint, a deeper fit. The knee's bony shape alone doesn't create a locked-in situation.
So it needs help.
It's utterly reliant on a complex system of supporting structures to keep it stable throughout its huge range of motion and under really significant loads. The source categorizes these stabilizers beautifully into two key groups, static and dynamic.
Okay, static and dynamic. Let's unpack those. Static stabilizers, those are the passive bits, right? The structures just holding things together.
Yeah, think of them like the biological equivalent of ropes, tapes, and cushions. The source lists these as the joint capsule itself, the menisci, which we'll definitely get into, and the ligaments.
And the dynamic ones.
Those are the active players, the muscles that cross the joint. The source specifically calls out the powerful quadriceps group on the front of your thigh and the hamstring muscles on the back. They actively contract, control movement, and provide stability by pulling across the joint, working together with those static structures.
So you absolutely need both the fixed ropes and the active muscle control for the knee to work right. It's this intricate interplay.
Absolutely. And understanding the interplay is fundamental, because if you lose stability from one system, say a ligament tears, the other system, like the muscles, often gets overloaded trying to compensate, which can lead to further issues down the line.
Let's really focus in on those key static structures the source mentions, starting with something absolutely vital that sits right in the middle, the menisci.
Right. The source describes these as semilunar or kind of crescent-shaped structures made of fibrocartilage.
Fibrocartilage, so that's different from the smooth cartilage on the bone ends.
Yes, it's tougher, more fibrous. Think of it as a sort of blend between dense connective tissue, like ligaments, and cartilage. These menisci are interposed, basically sandwiched between the top of the tibia, the tibial plateau, and those rounded femoral condyles.
Like washers or gaskets in there?
Kind of, yeah. You can visualize them sitting on top of the tibia like slightly mobile rings or wedges.
And they're not just passive cushions. The source highlights their absolutely crucial roles. First, shock absorption, which makes sense, soaking up impact. But second, and this is where the biomechanics gets really interesting, they significantly increase the area over which load is dissipated. What does that actually mean?
This is a really critical insight from the source. Imagine those rounded femoral condyles resting on the relatively flat tibial plateau. Without the menisci, the contact area would be quite small, like trying to balance a ball on a plate.
Okay, so high pressure points.
Exactly. Very high pressure, concentrated on small areas of that smooth articular cartilage covering the bone ends. The menisci transform that small contact area into a much larger, more congruent surface. They essentially make the flat tibial top more concave, creating a better cradle for the rounded femur ends by spreading that contact area out.
They spread the load out, reduce the pressure.
Precisely. They act like sophisticated load distributors, drastically reducing the peak pressure on the hyaline cartilage. This load dissipation function is absolutely paramount for protecting that cartilage from wear and tear.
Wow, okay. That's more complex than just cushioning.
Definitely. The source also mentions a third role, providing some antero-posterior stability, helping to prevent the tibia from sliding too far forward or backward relative to the femur, sort of complementing the job of the cruciate ligaments.
So cushioning, load distribution, a bit of stability. Given those vital jobs, the clinical implication when something happens to the meniscia, it's got to be significant.
Oh, absolutely. The source points this out directly. Loss of that protective function, whether from an injury, age-related degeneration, or surgical removal, which is called meniscectomy, can drastically accelerate degenerative changes in the joint. It can lead rapidly to osteoarthritis.
Because you lose that load spreading ability.
Exactly. The pressure on the articular cartilage spikes, and it just wears out much, much faster.
The source mentions how menisci tear, noting that medial meniscal tears on the inside are about 3 times more common than lateral or outside tears. Any reason for that?
Well, the source describes the lateral meniscus as being more mobile than the medial one. It's not quite as firmly attached around its periphery. This extra mobility might offer it some protection against certain twisting forces compared to the more fixed medial meniscus.
Okay. But the source really emphasizes that certain tear patterns are particularly devastating, regardless of which side it is.
Yes, and this is one of those key details that really drives home the function. The source specifies that tears or surgical removal that disrupt the circumferential fibers, the fibers running around the curve of the meniscus, and crucially, defunction, the protective hoop stresses, are particularly damaging.
Hoop stresses. What's that?
Okay, think of a wooden barrel. It's held together by metal hoops running around it, right?
Yeah.
Those hoops are under tension, holding the wooden staves together. The meniscus works similarly. Its circumferential fibers run around its curve. When you put compressive load down through the knee, the menisci gets squeezed. This squeezing puts tension into those circumferential fibers, creating hoop stress.
Whoa.
This hoop stress allows the meniscus to resist being pushed outwards and helps it distribute the load evenly across the tibial plateau. Now, if you have a tear that cuts across those fibers, the source mentions a radial tear specifically, like a cut from the inner edge outwards. Or if the meniscus tears off as attachment points to the bone, the root attachments.
You break the hoop.
You break the hoop, exactly.
Yeah.
The meniscus can no longer withstand that compressive load by generating hoop stress. It tends to collapse or extrude outwards, and its ability to dissipate load is severely compromised. Removing large portions surgically also obviously disrupts this.
Wow. So it's not just that it's torn, but where and how. A tear that breaks that hoop mechanism is functionally way worse. The source says these types of damage can cause rapid deterioration of the joint. That makes perfect sense now you've lost that fundamental load-sharing capacity.
Exactly. Understanding the hoop stress mechanism is really key to appreciating why certain tears are treated maybe more urgently or have a worse long-term outlook if they can't be repaired.
Okay, now moving to the other key static stabilizers, the ligaments. Let's talk about the collateral ligaments, the ones on the sides of the knee.
Right, you have the medial collateral ligament, or MCL, on the inside, and the lateral collateral ligament, LCL, on the outside. The source identifies them as the primary response to valgus and varus stress.
Valgus and varus stress, remind me.
Valgus stress is a force pushing the knee inwards towards the other leg. Think of getting tackled on the outside of your knee. This stretches the MCL on the inside.
Okay.
Varus stress is the opposite, a force pushing the knee outwards, away from the midline, like a blow to the inside of the knee. This stretches the LCL on the outside.
Got it. And the MCL.
The source describes the MCL as broad and flat, with two layers, a superficial and a deep layer. The deep layer is actually attached to the medial meniscus and the tibia quite close to the joint line, which is why sometimes you see MCL and medial meniscus tears together. The superficial layer attaches a bit further down the tibia.
And the MCL is injured pretty often, right? Especially in sports. But the source gives us a significant clinical point here. It frequently heals with conservative management.
That's a key piece of information from the source, yeah.
Ah.
Resting it, maybe bracing, physical therapy, often, that's enough for the MCL to heal up without needing surgery. It has a pretty good blood supply compared to some other ligaments.
Okay, that's good news. But contrast that with the LCL on the outside.
Right. The LCL is described as a simpler, more cord-like structure. But the source emphasizes it doesn't work alone. It's a key component of a more complex group of structures called the lateral or posterolateral ligament complex.
A complex?
Yeah, it's a team effort on that outer side. It includes the LCL itself, but also the popliteus muscle tendon, the biceps femoris tendon attachment, something called the popliteofibular ligament, the iliotibial band running down the side, and parts of the joint capsule. They all work together for stability on that side, especially against rotation and varus stress.
So the outside of the knee relies on this whole team working together. And the source says injuries to the LCL, especially involving this posterolateral corner complex, they're less likely to heal well conservatively.
Correct. The source states they are more likely to require surgical reconstruction. This highlights the intricate biomechanics and the reliance on multiple structures on that lateral side. Injuries there, especially combined ones, tend to be more serious in terms of needing surgery compared to a typical isolated MCL tear.
Okay, now to the famous ones, the ligaments right in the center that cross over, the cruciate ligaments.
The anterior cruciate ligament, the ACL, and the posterior cruciate ligament, the PCL. Named because they form a cross inside the joint. Cruciate means cross-shaped. The source mentions each ligament is actually made up of two distinct bundles of fibers.
Right. The ACL has an anteromedial bundle, tight when the knee is bent, and a posterolateral bundle, tight when the knee is straight. And its main job, the source says, is to stop the tibia from sliding too far forward relative to the femur.
Correct. It's the primary restraint against anterior tibial translation.
And the PCL does the opposite.
Pretty much. It also has two parts, or bundles, an anterolateral bundle, tight in flexion, and a postfemedial portion, tight in extension. Its main function is to prevent the tibia from sliding too far backward relative to the femur. It's the primary restraint to posterior tibial translation.
So these cruciates are absolutely fundamental for that front-to-back stability, but also help with rotational stability, right? Especially during pivoting.
Yes, they play a role in rotational control too. Now the source distinguishes the context of injuries to these ligaments. It says single ligament injuries, like an isolated ACL tear or meniscal tears, most commonly happen during sport. Often a non-contact twisting injury, hyperextension, or an awkward landing.
But then it contrasts this with multiple ligament injuries.
Right. This is where things get much more serious. Multiple ligament injuries involve complete tears of two or more of the four main stabilizers: ACL, PCL, MCL, LCL posterolateral complex. The source explicitly associates these with high-energy trauma. Think car crashes, falls from significant height.
And the consequence of these multi-ligament injuries, it sounds severe.
It really underscores the severity. The source states these can result in a complete dislocation of the knee joint, where the femur and tibia completely lose contact. This isn't just a sprain, it's a true orthopedic emergency. And critically, the source emphasizes it's associated with a high risk of damage to the major arteries and nerves that run right behind the knee.
So potentially limb-threatening.
Absolutely. It highlights that huge difference between a common sports injury, like an ACL tear, and the devastating potential of high-energy trauma causing multiple ligaments to fail.
Okay, let's move on to the tissue covering the bone surfaces themselves, the one the menisci protect, that smooth, white, hyaline articular cartilage.
The source describes this as a highly specialized connective tissue. It provides that incredibly smooth surface at the ends of the bones within the joint. Its key feature is its extremely low coefficient of friction.
Meaning it's super slippery.
Exactly. Allows the bones to glide over each other almost effortlessly, minimal resistance, enabling smooth motion.
But here's the critical detail the source highlights, which has huge implications for treatment. This tissue is devoid of blood vessels, lymphatics, and nerves.
Yes, that's fundamental. It doesn't have its own blood supply to bring in nutrients and healing factors. It doesn't have lymphatic vessels to clear away waste products effectively. And it doesn't have nerve endings, which is why early cartilage damage itself might not hurt, though the consequences eventually do. But that lack of blood supply means it has a very, very limited capacity for repair.
So if you damage it, it doesn't really fix itself?
Not effectively, no. Not like skin or bone can heal. The source also notes that its structure changes with aging and disease, making it more brittle or susceptible to injury in the first place.
That's a fundamental limitation we have to deal with biologically. And finally, the source briefly mentions bursae.
Right, these are just small fluid-filled sacs located around the knee joint, usually between tendons and bones or skin and bones. They act like little cushions to reduce friction during movement. The source notes they can become inflamed, that's bursitis, and sometimes even infected.
Okay, so to quickly synthesize the foundational anatomy from the source, we've got this complex, inherently unstable synovial hinge joint. It's stabilized by key static structures, the capsule, those crucial load-dissipating menisci, remember the hoop stress, the collateral ligaments providing side-to-side stability, MCL inside, LCL outside, and the cruciate ligaments, ACL and PCL, critical for front-to-back and rotational control. And all this works together with the dynamic muscle forces from the quads and hamstrings.
That's a good summary. Understanding those components is the starting point. Now let's put them into motion and look at the biomechanics, how this all functions under load, how it moves, and importantly, why alignment is so critical.
Right, and this is where the source introduces something really crucial for understanding alignment and orthopedic surgery, the axes of the lower limb.
Absolutely vital concept. The source defines two main axes. First, the anatomical axis. These are simply lines drawn down the center of the bone shafts, basically down the hollow medullary canals of the femur and the tibia, just straight down the middle of each bone.
Okay, and the second one.
That's the mechanical axis. This is the line that represents the true direction of weight bearing when you stand. It's drawn from the center of the femoral head, way up at your hip joint, down through the intercondylar notch of the knee, that groove between the femoral condyles where the cruciates attach, and continues all the way down to the center of the ankle joint. That's the load line.
The low, okay. And the source makes a critical distinction between these two axes.
Yes. It states that the mechanical axis and the anatomical axis line up perfectly. They're coincident in the tibia. The shin bone is pretty straight, but, and this is key, right, Of? They do not line up in the femur.
Why is that difference in the femur so important?
Because your femur angles inwards from your hip down to your knee. Think about it. Your hips are wider apart than your knees. So the anatomical axis down the shaft angles inwards, but the mechanical axis, hip center to ankle center, is a more vertical line. The source quantifies this. The angle between the femoral anatomical axis and the mechanical axis is typically between 5 and 7 degrees.
And this angle has a specific name in surgery.
Yes. The source helpfully notes this is often called the valgus cut angle in total knee arthroplasty. It's a specific angle surgeons often use when making the bone cut on the femur during a knee replacement, aiming to restore that proper mechanical alignment. It directly links this biomechanical principle to surgical planning.
So that mechanical axis is the true line of force transmission from hip to ankle. And understanding where that line passes through the knee joint is critical because, as the source emphasizes, knees with malalignment, meaning that mechanical axis is shifted away from the center.
Right, shifted either inwards, which is varus, or bow-legged.
Or outwards, valgus, or knock-kneed.
Those knees are more prone to injury or degeneration in the overloaded compartment.
Makes sense. If the weight line is shifted inwards, the medial side takes too much stress. Shifted outwards, the lateral side gets overloaded.
Exactly. And over time, that chronic overloading just wears out the cartilage in that compartment much faster than the other side.
And this biomechanical principle leads directly to one of the surgical options discussed later, realignment surgery or osteotomy.
Precisely. The source explains the whole purpose is to surgically cut and realign the bone to correct that faulty alignment, shifting the mechanical axis back towards the center or maybe even slightly into the healthier compartment. This offloads the damaged area, reduces the excessive pressure, aims to decrease pain, and potentially slow down the arthritis progression. It's surgery based entirely on fixing the load distribution.
Okay, now let's talk about the actual motion of the knee, the kinematics, how it moves. The source says the main motion is in the sagittal plane flexion and extension, bending and straightening.
Yes, that's the primary movement, like a hinge. All right. But again, the source adds complexity. It highlights that there's also a limited amount of rotation that occurs, axial rotation. And importantly, this rotation increases as the knee bends more. You get more rotational play when your knee is flexed compared to when it's fully straight.
And how does the knee actually move during flexion? It's not just a simple pivot.
No, it's more complex. The source, referencing imaging studies like MRI, reveals it's a combination of rolling and sliding of the femoral condyles on the tibial plateau. The femur ends roll back as you bend, but they also slide forward or backward, depending on the degree of flexion.
Rolling and sliding.
Yes. And in addition to that roll slide, there's that crucial element of axial rotation we mentioned. Specifically, internal rotation of the tibia relative to the femur happens as the knee bends from full extension into flexion. And the reverse, external rotation of the tibia, happens as you straighten it fully. This coupled motion is sometimes called the screw-home mechanism.
Why does this complex motion happen? Why the rolling, sliding, and rotation? What drives it?
The source explains it's primarily due to the different shapes and sizes of the femoral condyles. The medial femoral condyle, the one on the inside, is larger and has a slightly different curvature than the lateral one. As you flex your knee, the source says the larger medial condyle rolls back less than the smaller lateral condyle. This difference in rollback distance causes the tibia to internally rotate relative to the femur.
Ah, okay. So the asymmetric shape of the femur itself drives this complex coupled motion.
Exactly. And the source points out that this is facilitated by some of the structures we discussed earlier, specifically the more mobile lateral meniscus and the lateral ligaments that tend to be more lax in flexion. They provide the necessary give or flexibility on the outer side of the joint to allow this differential movement and rotation to occur smoothly.
And the normal range of motion.
The source gives typical values between about 5 degrees of hyperextension, bending slightly backward past straight, and 100 to 35 degrees of flexion, bending fully.
Okay. Finally, in biomechanics, we have to talk about the patella, the kneecap. The source assigns it a surprisingly powerful role.
It's crucial. Its main biomechanical function, as the source states, is to act as a pulley for the quadriceps muscle.
A pulley. Explain that simply.
Okay, imagine your quadriceps muscle is the engine pulling a rope, the quad tendon. The patella is like a pulley wheel that the rope runs over before it attaches down on the tibia via the patellar tendon. By sitting out in front of the knee joint, the patella lifts the tendon away from the center of rotation of the knee.
Okay.
This lifting action increases the lever arm of the quadriceps muscle. Think about using a wrench. A longer handle gives you more leverage, more turning force.
Right, more mechanical advantage.
Precisely. By increasing that lever arm, the patella significantly increases the power output of the quadriceps. It allows your quad muscle to straighten your knee much more efficiently and forcefully than if the tendon just ran straight down from the femur to the tibia.
And the source gives a truly stunning statistic about the forces this little bone handles.
It's incredible. It states the patella has the thickest articular cartilage in the body, which is a clear sign it's built for heavy load. And it's designed to withstand forces as high as 20 times body weight during activities like jumping.
20 times body weight on that small surface.
It's an enormous force. It really underscores the incredible load-bearing capacity required and the vital role the patella plays in anything involving forceful knee extension, jumping, running, climbing stairs.
So the clinical implication noted by the source is clear. If anything disrupts this finely tuned pulley system issues with alignment, the shape of the patella itself or the groove it runs in on the femur, tightness in the surrounding soft tissues, or muscle imbalances, it can lead to dysfunction. Problems like pain or even patellar dislocation, where the kneecap actually pops out of its groove.
That covers the core biomechanics. It's about the axis dictating load, the complex rolling and sliding motion, and the patella acting as that vital power-boosting pulley handling massive forces.
Right. With that solid understanding of how the knee is built and how it's supposed to work, let's turn to the conditions that affect it when this intricate system starts to go wrong. The source says the most common issues are soft tissue injuries and osteoarthritis.
Yes, and they can show up acutely, right after a specific injury, or develop more gradually as chronic, long-standing problems.
Let's revisit those soft tissue problems, starting with the menisci again, but now from a clinical perspective. How do tears present?
Well, as we said, tears can happen in either the medial or lateral meniscus and have different patterns: circumferential, radial, horizontal, flap tears, or just degenerate wear. For actually diagnosing these, the source is clear. An MRI scan is the investigation of choice. It gives really detailed pictures of the menisci and all the other soft tissues inside the joint.
And the source repeats that critical point. Meniscal tears seldom heal on their own. That's fundamental to understanding treatment, right?
Absolutely. Because they have such a poor blood supply, especially in the inner parts, They just don't have the biological machinery to repair themselves effectively most of the time.
So this leads to the different management approaches outlined in the source, depending on the tear and the symptoms.
Exactly. For tears that happen with a specific injury, especially if they cause mechanical symptoms, things like the knee catching, locking up, or suddenly giving way, the source says these generally respond well to arthroscopic repair or debridement.
Arthroscopic, meaning that keyhole surgery. And the source gives specific factors that make a tear a good candidate for repair versus just cleaning it up.
Yes, and these are crucial criteria from the source. Younger patient age, better healing potential generally, getting it treated fairly soon after the injury, a simple tear configuration, like a clean split, not shredded, overall knee stability, like an intact ACL, and most importantly, the tear needs to be located in the vascular outer third of the meniscus. That peripheral zone is the only part with enough blood supply to potentially heal if the edges are stitched back together.
So repair is the goal in the right circumstances, especially for younger active people. But what about those degenerate tears, the ones often seen in older joints without a single clear injury event?
The source makes a clear distinction here. Degenerate tears, particularly if they don't cause those distinct mechanical symptoms like locking, are primarily treated conservatively. So, non-surgical management, first pain relief, physiotherapy, maybe activity modification. Arthroscopy is considered only after that conservative approach has failed to adequately relieve the symptoms. The approach really differs based on the likely cause and the type of symptoms.
Okay, that makes sense. Moving to the next common soft tissue problem, anterior cruciate ligament, ACL, injury.
The source calls this the most common serious ligament injury in the knee. It's usually caused by a non-contact twisting or landing mechanism, frequently happening in pivoting sports, think soccer, basketball, netball, skiing where the foot is planted, but the body twists or shifts over the knee.
And there's a classic presentation described in the source that really paints a picture.
Yes, it's often associated with hearing or feeling an audible pop sound at the time of injury. This is followed pretty quickly by significant swelling of the whole knee joint. It's usually blood filling the joint from the torn ligament and capsule, a hemarthrosis. The player is typically unable to continue playing and may need to be carried off the field or court.
The source also identifies risk factors, noting a higher risk among females. Any ideas why?
The source suggests a few possible reasons. Maybe anatomical factors like women tending to have slightly smaller ligaments or smaller notches in the femur where the ACL runs. Also, potential differences in neuromuscular control and landing biomechanics compared to males might play a role. It's likely multifactorial.
What are the consequences if an ACL tear isn't treated surgically and the person remains active?
The source states that chronic ACL deficiency, meaning the ligament isn't functioning, can cause significant functional instability. The knee might feel like it gives way during certain movements, and this repetitive giving way over time can lead to secondary damage to other important structures in the knee, specifically complex tears of the menisci and damage to the articular cartilage, which accelerates the onset of arthritis.
How is an ACL tear diagnosed clinically, besides the story?
Diagnosis relies on the history, a physical examination, and imaging. On examination, specific tests that stress the ACL will be positive, showing increased forward movement of the tibia relative to the femur. The key ones mentioned are the Lackerman test and the pivot shift test. The source confirms that an MRI scan is used to definitively diagnose the ACL rupture itself, and very importantly, to identify any associated injuries like meniscal tears, other ligament damage, or bone bruising.
So once it's diagnosed, how is an isolated ACL injury managed initially?
The source states that initial management is generally non-operative. The first step is to let the acute injury settle down. This involves RICE rest, ice, compression, elevation to reduce swelling, managing pain, maybe using a knee brace for support temporarily, and starting physiotherapy early on to restore range of motion and begin strengthening the muscles around the knee, particularly the quads and hamstrings.
When does surgical reconstruction become the recommended path?
Surgical reconstruction, where the torn ACL is replaced with a graft, is considered in specific situations outlined by the source. First, if the patient has multiple ligament injuries, ACL reconstruction is usually part of that bigger repair. Second, in cases where the knee continues to feel unstable and give way despite a good course of non-operative management and rehab. And third, crucially, it's often recommended for young patients or high-demand athletes who intend to return to activities that involve significant pivoting, cutting, and jumping. The source notes these individuals are more likely to fail conservative treatment if their goal is to get back to those high-level sports.
And the timing of the surgery matters. You don't rush into it.
No, generally not. The source advises that reconstruction is best done once the knee has recovered from the acute injury. This means the swelling has largely resolved, the patient has regained good or near normal range of motion, and has reasonable muscle function, especially quad control. Operating on a knee that's still very stiff and swollen significantly increases the risk of post-operative stiffness, a condition called arthrofibrosis.
Okay. Another significant soft tissue injury the source covers is rupture of the extensor mechanism. What does that involve?
This refers to a tear of that critical link that allows you to straighten your knee against gravity. It's either a tear of the quadriceps tendon, which connects the big quad muscle to the top of the patella, or a tear of the patellar tendon, which connects the bottom of the patella to the tibia.
How do these happen?
The source says they are typically high-energy injuries, like a sudden forceful contraction of the quad muscle against resistance, maybe during a fall or jump.
But the source also notes they can happen with less force in certain situations.
Yes, it adds that nuance. They can occur more easily in people who have underlying conditions that weaken the tendon, like chronic kidney disease or diabetes, or in those on long-term steroid use. Also, previous steroid injections directly into or around the tendon can weaken it, as can previous open knee surgery that might have disrupted the blood supply to the tendons.
And the presentation sounds pretty dramatic.
It is. The source describes significant pain and swelling right over the front of the knee, often with a palpable gap where the tendon tore. And the hallmark sign is the inability to actively extend the knee. The person simply cannot lift their lower leg straight out against gravity while sitting or lying down.
That sounds completely disabling.
It's a profound functional loss.
Yeah.
You can't walk normally without the knee buckling. And the source is very clear on management. Prompt surgical repair or reconstruction is required. Delaying surgery makes the repair much harder as the tendon retracts and scars down and leads to a significant long-term loss of knee function. The torn ends need to be surgically reattached.
We touched on articular cartilage injury earlier, talking about its limited repair capacity. The source also covers this as a clinical issue.
Yes, isolated articular cartilage injuries can happen, often from trauma, or they can be associated with other injuries like ACL tears or patellar dislocations when the joint shifts abnormally. And as we noted based on the source, the prognosis for healing depends heavily on the depth of the damage. The source states partial thickness defects do not show any potential to heal.
Still striking. No potential at all for partial thickness.
That's the information from this source, yeah. They don't typically fill in. Now, for full thickness defects where the damage goes all the way down to the underlying bone in younger patients, the source says the body may mount a healing response. But it's typically with fibrocartilage. And remember, that's a scar-like cartilage, mechanically inferior, less durable than the original smooth hyaline cartilage.
What about osteochondral injuries? That sounds like bone is involved too.
Exactly. The source mentions these occur in higher energy injuries when a piece of the underlying bone actually breaks off along with the overlying cartilage surface. So you have a fragment containing both bone and cartilage.
So, given cartilage's limited healing, how are these injuries managed surgically according to the source? What are the options?
The source outlines several approaches, and the choice depends on factors like the patient's age, activity level, and the size and location of the defect. If an osteochondral lesion, that bone and cartilage fragment, is detected acutely, soon after injury, and the fragment is large enough and the bone quality is okay, the source says it may be surgically fixed back in place with screws or pins.
Okay, trying to put it back together.
Right. For full-thickness cartilage defects, especially if they're causing symptoms, the options become more complex. They include simply removing the loose body if a fragment has broken off and is floating around, or procedures aimed at stimulating some healing. Microfracture involves creating small holes in the exposed bone surface to allow bone marrow cells and blood to seep out and form a clot, hopefully leading to fibrocartilage formation. Sometimes this microfracture is covered with a collagen membrane to help contain the clot.
More advanced options.
Yes, things like osteochondral transplant procedures. Mosaicplasty involves taking small cylindrical plugs of healthy bone and cartilage from a less critical area of the patient's knee and transplanting them into the defect, like fitting mosaic tiles, or chondrocyte transplant techniques like ACI, autologous chondrocyte implantation, or MACI, matrix-assisted ACI. These involve harvesting a small piece of the patient's own healthy cartilage, growing those cells, chondrocytes, in a lab to multiply them, and then implanting them back into the defect, often under a patch or within a scaffold, to try and regenerate more hyaline-like cartilage.
Wow, that's a really complex range of techniques. Really highlights the challenge of fixing cartilage.
Absolutely. The source emphasizes that the choice among these advanced options is carefully determined by the age of the patient and the site and size of the defect. These are generally considered joint preservation strategies, trying to repair a specific hole, distinct from treating widespread cartilage loss like we see in osteoarthritis.
And that leads us perfectly to the major degenerative challenge for the knee, osteoarthritis or OA.
The source highlights just how common OA is in the knee. It gives prevalence figures. Around 10% of men and 13% of women aged 60 or older have symptomatic knee OA. That's a huge number of people affected, representing a massive healthcare burden.
And the source breaks down the causes into primary and secondary types.
Right. Primary or idiopathic OA means we don't know the exact cause, but it often affects multiple joints and can have a genetic component running in families. Secondary OA occurs as a direct consequence of some prior event or condition that damaged the joint. The source lists examples: a previous intra-articular fracture, a break into the joint surface, having had a meniscectomy years ago, remember how that accelerates wear, a significant ligament injury like an untreated ACL tear leading to abnormal joint mechanics, osteonecrosis, where a section of bone near the joint dies, or OA developing in a neuropathic joint, like a Charcot joint seen in diabetics with nerve damage.
So many of the injuries we just discussed can directly set the stage for secondary OA years down the line. What does knee OA actually feel like for the patient, according to the source? What are the clinical features?
Patients typically describe pain, stiffness, and swelling in the knee. The source emphasizes that the pain is characteristically worse with loading and with activity, things like climbing stairs, walking distances, getting up from a chair, standing for long periods. It's often relieved by rest, at least in the earlier stages.
Is there a specific pattern for pain if the OA is mainly in the patellofemoral joint, the kneecap part?
Yes. The source notes that pain originating specifically from patellofemoral OA is often worse when going up or down stairs, and particularly when rising from a seated position after sitting for a while. This is because those activities put significant compressive force through that kneecap joint.
What's the typical progression? Does it just stay the same?
Unfortunately, no. The source describes the natural history as usually a gradual, steady deterioration over years. It often starts with intermittent pain or short-lived flare-ups, perhaps after overdoing it. But over time, it tends to progress to more constant pain, and eventually, pain that frequently interferes with sleep.
And functionally.
Functionally, the patient's mobility declines. Their walking distance gets shorter and shorter. They may start needing walking aids like a cane or walker. In severe end-stage cases, the source says patients can become dependent on a wheelchair or even become housebound due to the debilitating pain and stiffness.
What does a doctor typically find when examining someone with knee OA?
The source details several key findings. First, observing their gait, their walking pattern. They often show an antalgic gait. That's basically a limp, where the patient instinctively spends less time bearing weight on the painful leg and shifts their body's center of gravity away from that side to try and minimize the load going through the painful joint. You might also see visible deformity. In the most common pattern of knee OA affecting the medial compartment, the deformity is typically varus or bow-legged. This happens because the cartilage wears away more on the inner side, leading to bone loss and the leg bowing outwards at the knee. The source also mentions that valgus deformity, a knock-kneed appearance, is less common in primary OA, but can be seen, particularly in women, or in conditions like rheumatoid arthritis, or sometimes after a lateral meniscectomy.
What about the joint itself? Does it look different?
Yes. The joint often appears bulky or swollen. The source attributes this to several things: an effusion, which is excess fluid within the joint capsule, thickening of the synovial lining, the joint lining gets inflamed, called synovitis, and the presence of large osteophytes, which are bone spurs growing around the edges of the joint. An effusion is frequently present and can make the knee feel tight and stiff.
And movement.
Movement is often restricted, particularly achieving full extension, getting the leg completely straight. Flexion might also be limited due to stiffness, swelling, pain, and those bony spurs blocking motion.
And that crunching or grinding sound or feeling?
That's crepitus. The source notes it can often be both palpable, the examiner can feel it with their hand on the knee during movement, and sometimes even audible, you can hear it crunching. It's literally the sound and sensation of the roughened cartilage and exposed bone surfaces grinding against each other.
So how is OA investigated definitively? Do you always need fancy imaging like an MRI?
Actually, no. The source is quite practical here. It clearly states that plain radiograph standard X-rays are the investigation of choice for diagnosing typical knee OA. And crucially, it specifies why weight-bearing views are best.
Why weight-bearing?
Because taking the X-ray while the patient is standing up puts their body weight through the joint. This best demonstrates the true extent of joint space narrowing, which is the key sign of cartilage loss. When you're lying down, the joint space might look artificially wider. Weight-bearing views show how much space is really left under load.
Okay. What are those key features the doctor looks for on the X-ray?
The source lists the classic radiographic signs of OA. First, joint space narrowing, usually asymmetric, meaning worse in one compartment, typically medial. Second, subchondral sclerosis, which is increased bone density or hardening of the bone right beneath the worn-away cartilage, the bone's reaction to increased stress. Third, osteophytes, those bony spurs forming around the joint margins. And fourth, sometimes subchondral cysts, which are fluid-filled cavities that can form within the bone just below the joint surface.
And MRI, not usually needed for standard OA.
The source clarifies that an MRI scan is not routinely required prior to knee replacement for typical degenerative OA. The X-rays usually provide all the necessary information about the extent and pattern of the arthritis for diagnosis and surgical planning. MRI might be used if there's suspicion of other problems, but not just for standard OA confirmation.
Okay, so OA is diagnosed with the patient's story, the physical exam, and those weight-bearing X-rays. How is it treated, according to the source? Is surgery the first step?
Definitely not. The source outlines a clear staged approach, always started conservatively. The first line of treatment is non-operative methods.
What does that involve? Things the patient can do.
Yes. A lot of it is lifestyle modification and self-management. Recommendations include weight loss. Even modest weight loss can significantly reduce the load on the knee joint and decrease pain. Regular exercise is encouraged, specifically low-impact activities like swimming, cycling, or walking, which help maintain joint mobility, strengthen the surrounding muscles, which act as shock absorbers, and improve overall function without excessively stressing the joint. And using anti-inflammatory medication, both over-the-counter like ibuprofen or naproxen and sometimes prescription ones, to manage pain and reduce inflammation, especially during flare-ups. Other conservative options mentioned in the source include using walking aids like a cane held in the opposite hand to the painful knee, or crutches to offload the joint. Sometimes orthotics, special shoe inserts, can help improve alignment slightly, and specialized offloader braces can be beneficial for some people, particularly those with arthritis predominantly in one compartment. These braces apply an external force to try and shift weight away from the damaged area.
What about injections? The source mentions steroid injections. Are they a long-term fix?
They can provide temporary relief. Intra-articular steroid injections work by reducing inflammation within the joint, which can calm down an acute arthritic flare-up and decrease pain for a period, maybe weeks or sometimes months. However, the source makes a crucial statement here. They are no longer recommended as a long-term solution.
Why not?
Because of growing concerns about potential downsides. There's always a small risk of introducing infection into the joint with any injection. And perhaps more importantly, there's increasing evidence suggesting that repeated steroid injections might actually cause further damage to the remaining articular cartilage over time. So they're seen more as a temporary measure for symptom control, not a treatment for the underlying disease.
Okay, so short-term relief, maybe to help someone get through a bad patch or participate in physio, but not a cure. When do surgical options come into play for OA?
Surgery is generally reserved for the later stages of the disease. The source indicates that surgical interventions, which include osteotomy, that realignment surgery for earlier localized OA, partial knee replacement, UKR, total knee replacement, TKR, or, in very rare cases, arthrodesis, fusion, are considered when those non-operative treatments are no longer effective at controlling the patient's pain and maintaining an acceptable level of function and quality of life. It's for end-stage disease where conservative measures have failed.
Okay. That gives us a clear picture of OA, common primary or secondary causes, pain worse with use, those exam findings like limping, deformity, swelling, crunching, diagnosed by weight-bearing X-rays showing those key features, and treatment progressing from non-operative first to surgical replacement, usually for end-stage disease.
Exactly. That covers the clinical condition. Now, let's transition to those surgical procedures that offer solutions when OA or other conditions become severe enough to warrant intervention.
The source starts this section by making a basic distinction between the two main surgical approaches, arthroscopic versus open surgery.
A fundamental difference, yeah. Arthroscopic surgery, often called keyhole surgery, uses very small incisions, or portals. A tiny camera, the arthroscope, is inserted through one portal to visualize the inside of the joint on a monitor, and specialized miniature instruments are inserted through other portals to perform the surgery. Open surgery, on the other hand, involves making a larger incision to directly expose the joint structures for the procedure.
And the choice depends on what needs doing.
Precisely. The source states that arthroscopic treatment is possible for most soft tissue problems occurring inside the joint. Things like dealing with meniscal tears, repair or removal, reconstructing ligaments like the ACL or PCL, removing loose fragments of bone or cartilage, performing certain cartilage regeneration procedures, washing out an infected joint, removing inflamed synovial tissue, or a synovectomy, sometimes just for diagnostic purposes to get a clear look inside, or even assisting in the reduction of certain types of fractures around the knee.
So it's versatile for those internal issues.
Very much so. Open surgery, requiring more extensive access and direct visualization, especially of the bone surfaces, is necessary for procedures like osteotomy, bone cutting and realignment, partial or total joint replacements, and arthrodesis, joint fusion.
Okay, so arthroscopy for many internal soft tissue fixes, open surgery for the bigger bony reconstructions or replacements. Let's look at some specific surgical techniques in more detail now, starting with meniscal surgery, but seen from the surgeon's viewpoint using arthroscopy.
Right. Meniscal surgery is typically performed arthroscopically, usually using two standard small portals on the front of the knee. It's often done as an outpatient or day case procedure under general or sometimes regional anesthesia. Once the camera and instruments are inside, the surgeon thoroughly inspects the meniscus, confirms the tear pattern, its location, and critically assesses whether it's in that peripheral vascular outer third, the part that has some potential to heal.
If the tear is not in a repairable zone or it's too shredded or complex, what's the procedure then?
In that situation, the source says the goal is to remove only the unstable, torn, or unhealthy parts of the meniscus, trimming it back until you reach a healthy, stable rim. This is done using specialized arthroscopic instruments like punches, like tiny nibblers and shavers. This procedure is called debridement, or, more commonly, partial meniscectomy. You're removing the damaged bit that's causing symptoms like catching or locking, but aiming to preserve as much healthy meniscus tissue as possible, acknowledging its function will be reduced.
But if the tear is in a good spot for healing, maybe a clean longitudinal tear in that outer zone, especially in a younger patient,
then the source strongly advocates that attempts should be made to repair it. Common repairable tears mentioned are circumferential tears or bucket handle tears, where a large segment of the meniscus flips into the joint. The repair technique involves preparing the torn edges, sometimes roughening them up slightly to encourage bleeding, which brings healing factors, and then physically fixing the tear together using sutures or specialized meniscal repair devices. The source mentions different techniques for passing the sutures or devices, like inside out, outside in, or all inside methods, depending on the tear location and surgeon preference.
and the recovery after a repair must be different than just trimming it out.
Oh, significantly different. The source states that after a meniscal repair, post-operative protection is usually required to allow the repair to heal. This is critical. It typically means restrictions on weight bearing, often partial weight bearing, or even non-weight bearing for a period, and using a knee brace to limit certain movements, often for between 6 weeks and maybe even 3 months. This protection is essential to avoid putting stress on the delicate healing tissue.
Whereas recovery after just removing the torn piece, the partial meniscectomy, is usually much faster.
Generally, yes. After a straightforward partial meniscectomy, patients are usually allowed to bear weight much sooner and progress their activities more quickly, as there isn't a repair site that needs biological healing time.
Okay. Next up, cruciate reconstruction, focusing on the ACL. As the source says, it's the most common one needing surgery.
Right. An isolated ACL tear causing instability is most commonly treated with an arthroscopic intra-articular reconstruction. The basic idea is to replace the torn, non-functional ACL with a substitute tissue, called a graft, which is placed inside the joint in the same position as the original ACL.
What are the typical graft options used, according to the source? Where does this new ligament come from?
The source mentions the common autograft options, meaning the tissue is taken from the patient's own body during the same surgery. The two most frequent are the bone patellar tendon bone graft, BPTB, where the surgeon takes the central third of the patellar tendon along with small blocks of bone from the patella and the tibia where the tendon attaches. The other very common one is a hamstring tendon graft, usually using two of the hamstring tendons from the inner side of the thigh, semitendinosus and gracilis, which are then folded over to create a 4-strand graft. Using the patient's own tissue avoids any risk of disease transmission and generally allows for excellent biological incorporation into the bone.
How is this new graft actually secured inside the knee? It needs to be held tightly, right?
Absolutely. Bone tunnels are drilled very precisely in the femur and the tibia at the exact anatomical attachment points or footprints of the original ACL. The prepared graft is then passed through these tunnels. It's held securely in place under tension using various fixation devices, things like interference screws, which wedge the graft against the bone tunnel wall, or suspensory fixation devices like buttons or loops that hold the graft end suspended outside the tunnels. These devices provide the initial stability, holding the graft firmly while it biologically heals and integrates into the bone tunnels over many months, a process called ligamentization.
What's the expected recovery time for something like this? It sounds like a major reconstruction.
It is. The source provides a realistic timeline. Return to full, unrestricted sport, especially pivoting sports, can take up to a year, sometimes even longer. It's a lengthy process.
A whole year, wow.
Yeah, it involves not just the graft healing, but also regaining full strength, balance, neuromuscular control, proprioception, that's the sense of where your joint is in space, and crucially, the confidence to perform at a high level again. It requires a very structured and progressive rehabilitation program.
And the source highlights something absolutely crucial for a good outcome, besides just the surgery itself.
Yes, it strongly emphasizes that postoperative rehabilitation programs are crucial to a favorable outcome. You can have a technically perfect surgery, but if the rehab isn't done properly and diligently by the patient and therapist, the result can be suboptimal. Success is highly dependent on that commitment to many months of hard work and physiotherapy.
What about complications? What can go wrong with ACL reconstruction, according to the source?
Complications can occur, though thankfully they're not extremely common with modern techniques. The source notes that problems are often related to incorrect tunnel placement during the surgery. If the tunnels aren't positioned anatomically correctly, it can affect the graft's function. For instance, placing the femoral tunnel too far anteriorly, too far forward, can limit the knee's ability to fully flex. Performing the surgery too early, when the knee is still acutely swollen and stiff, is also mentioned as increasing the risk of complications, particularly postoperative stiffness, arthrofibrosis.
And the graft itself can tear again.
Yes, unfortunately, graft re-rupture can happen. The source gives an interesting statistic. The risk is approximately 1% per year after reconstruction. So while the surgery restores stability, the reconstructed ligament isn't necessarily identical in properties to the original ACL and remains vulnerable, especially if the patient returns to high-risk activities or suffers another significant injury.
Okay, let's move on to osteotomy, that realignment surgery we talked about when discussing biomechanics and malalignment.
Right. Osteotomy is performed specifically to address varus, bow-legged, or valgus, knock-kneed, malalignment that's causing abnormal loading and premature wear and tear, usually osteoarthritis, in just one compartment of the knee. The surgical aim, as the source describes, is to physically cut the bone, that's the osteotomy part, correct the angular deformity, and thereby alter the load-bearing mechanics of the joint. You're trying to shift the weight-bearing line away from the damaged area onto the healthier cartilage in the other compartment.
And the source states the most common type is a high tibial osteotomy, or HTO, typically done for a varus knee, where the intermedial compartment is overloaded.
Correct. The HTO involves making the bone cut in the tibia, usually just below the main knee joint line. The correction can be achieved in two main ways mentioned. An opening wedge medial HTO, where the bone is cut, and a wedge-shaped gap is opened on the inner side of the tibia, which is then held open with a plate and sometimes bone graft. Or a closing wedge lateral HTO, where a wedge of bone is removed from the outer side of the tibia and the gap is closed down, correcting the alignment. The opening wedge technique is generally more common nowadays.
This sounds like it requires very precise planning and execution. You have to get the angle just right.
It absolutely does. The source highlights that the exact amount of angular correction needed is carefully calculated preoperatively based on detailed measurements from specialized long leg x-rays that show the whole limb alignment. This planned correction is then created meticulously during the surgery using precise bone cuts, often guided by jigs, and the final alignment is usually checked with x-ray control in the operating room to ensure accuracy.
How is the bone held in its new corrected position while it heals after being cut?
Modern surgical techniques, as mentioned by the source, utilize internal fixation, usually with strong, specifically designed plates and locking screws. These implants provide rigid stability across the osteotomy site. This secure fixation is important because it allows for early weight bearing and mobilization after surgery, which significantly aids recovery and reduces stiffness compared to older techniques that required long periods of casting.
Who is the ideal patient for an osteotomy? It sounds like a joint preserving procedure, not a replacement.
It is exactly that, a joint preservation technique. The source specifies the ideal candidate profile. Typically a younger, say under 60, active and well-motivated individual who has arthritis or significant cartilage damage, predominantly limited to only one compartment of the knee, and whose other compartments and ligaments are relatively healthy. It's a way to buy time, relieve pain, improve function, and potentially postpone or even avoid the need for a joint replacement in someone who might be considered too young or too active for a replacement component. And that naturally leads us right into knee joint replacement surgery, which is the major intervention for more advanced widespread arthritis.
We established earlier that the knee has those three compartments: the medial and lateral tibiofemoral compartments, the main inner and outer parts of the hinge, and the patellofemoral compartment, the kneecap joint.
Yes. And the source uses this compartmental anatomy as a key factor in surgical decision-making for replacement. It states that in a significant proportion of cases, maybe 20–50%, the osteoarthritis primarily affects only one of these compartments. For these patients, the source says they are potentially suitable candidates for a partial or unicompartmental knee replacement, UKR. This procedure replaces only the damaged compartment, leaving the healthy parts of the knee intact.
Okay, so UKR for single compartment disease. What if the arthritis is more widespread, affecting two or all three compartments?
In that situation, which is called tricompartmental disease, the source indicates that a total knee replacement, TKR, is the appropriate procedure. TKR resurfaces all three compartments.
Let's delve into the UKR first, the partial replacement. What makes a patient truly suitable for this, according to the source? What are the criteria?
The source lists some key suitability criteria. First, the arthritis must be strictly limited to only one compartment, usually the medial, sometimes lateral. Second, the patient's collateral ligaments and, importantly, the ACL must be intact and functional because the UKR relies on the patient's own ligaments for stability. Third, any fixed deformity, bowing or knock knee that can't be passively corrected should generally be less than about 15 degrees. And they shouldn't have significant inflammatory arthritis like rheumatoid.
If a patient meets those criteria, what are the potential advantages of having a UKR compared to going straight to a TKR based on the source?
The source lists several potentially significant advantages. UKRs are associated with lower complication rates overall. The source cites figures suggesting maybe 1/3 to 1/2 the rate seen with TKR. They tend to have lower infection rates, lower medical risks during and after surgery, like heart attack or stroke, and even a lower risk of perioperative death. Furthermore, they're often associated with a more rapid recovery, a shorter hospital stay, better preservation of the knee's natural kinematics, how it moves, because you keep the cruciate ligaments in the other compartments. And the source states they can achieve generally superior function compared to TKR, feeling more like a normal knee in the right patient.
That's a really compelling list of benefits. Lower risks, faster recovery, better function. Why isn't UKR the standard approach then if only one compartment is clearly affected? There must be a catch.
There is a critical nuance here that the source provides, and it relates to longevity or durability. While the potential benefits are significant, the source points out that the revision rates, that's the rate at which the implant fails and needs to be redone for UKRs, are known to be significantly influenced by the surgeon's experience with the procedure and the specific implant design used. In the hands of highly experienced surgeons using well-established implants with good track records, the source suggests revision rates can be similar to those of TKR. However, when you look at the broader data from large national joint replacement registries, which collect outcomes from many surgeons with varying levels of experience in different implants, UKRs consistently show higher 10-year revision rates, around 6–12% compared to TKRs, which are typically in the 2–6% range.
That's a really important distinction. So while it can be potentially better for the ideal patient operated on by an expert using the right implant across the board, they seem to fail more often than TKRs by the 10-year mark.
Exactly. It suggests that achieving consistently excellent long-term results with UKR might be more technically demanding or sensitive to patient selection compared to TKR. It's a great operation for the right patient in the right hands, but perhaps less forgiving overall.
The source also briefly mentions isolated patellofemoral replacement, just replacing the kneecap joint.
Yes, it's performed, but the source notes the numbers are relatively low. This is mainly because truly isolated severe patellofemoral OA without significant arthritis in the main tibiofemoral compartments is relatively uncommon. And these isolated patellofemoral replacements also tend to have higher revision rates than other partial knee replacements, often because arthritis eventually progresses in the other initially spared compartments, necessitating conversion to a TKR later on.
Okay, now let's get to the workhorse. Total knee replacement, TKR. The source describes it helpfully as a resurfacing procedure.
That's a good way to conceptualize it, yeah. You're not cutting out huge chunks of bone and replacing the whole joint structure. Instead, you're precisely removing the damaged cartilage surfaces and a small amount of underlying bone from the end of the femur, the top of the tibia, and sometimes the back of the patella, and then capping or resurfacing those prepared bone ends with artificial components.
What are the components typically made of?
The end of the femur is resurfaced with a shaped metal component, usually cobalt chrome alloy. The top of the tibia is resurfaced, typically with a flat metal tray or base plate, also often cobalt chrome or titanium. And then a specialized durable plastic insert made of ultra-high molecular weight polyethylene is locked into the tibial base plate. This plastic insert becomes the new bearing surface that the metal femoral component articulates against. Sometimes the back of the patella is also resurfaced with a plastic button.
And the source calls TKR one of the most successful surgical interventions ever developed.
It truly is, particularly in terms of reliably relieving the severe pain of end-stage arthritis and restoring function and mobility for the vast majority of patients. The source notes that most people achieve significant pain reduction and a major improvement in their ability to walk and perform daily activities. The long-term survival rates of the implants are excellent, with revision rates typically being less than 5% at 15 years post-surgery with modern implants and techniques.
But the source makes an interesting comparison regarding patient satisfaction. It's not always perfect.
Yes, it notes that while highly successful objectively, patient satisfaction levels with TKR are generally reported to be somewhat lower than those achieved with total hip replacement. Why exactly isn't fully clear, but some patients after TKR may still experience some residual symptoms like mild stiffness, clicking or clunking noises, or a feeling that the knee isn't quite normal, perhaps more so than after a hip replacement.
How are the TKR components typically fixed into the bone?
The source states they are generally fixed to the prepared bone surfaces using polymethyl methacrylate, PMMA, bone cement. This is a type of acrylic cement that's mixed in the operating room and applied in a doughy state. It flows into the microscopic crevices of the bone and interlocks with the textured surface of the implant as it hardens rapidly, providing immediate, strong fixation. Cementless TKR options exist, but cemented fixation remains the gold standard for most cases, according to many sources.
What about the design of the articulation itself, how the femoral component moves on the plastic tibial insert? Are there different types?
Yes, the source explains that implant designs vary in the amount of inherent stability or constraint they provide. Unconstrained TKRs are the most common type used for primary first-time replacements. These designs rely primarily on the patient's own remaining collateral ligaments, MCL and LCL, and surrounding soft tissues for side-to-side stability, much like the native knee. These unconstrained designs are further classified based on how they handle the posterior cruciate ligament, PCL. Cruciate retaining CR implants are designed to keep the patient's PCL intact, assuming it's functional. PCL sacrificing, PS, or posterior stabilized, implants involve removing the PCL, and the implant itself has a built-in post on the tibial insert that engages with a cam mechanism on the femoral component to provide stability against backward sliding of the tibia.
So CR keeps the PCL, PS removes it and uses a mechanism instead. What about more constrained designs? What are they used?
More constrained designs provide more stability within the implant itself, meaning they rely less on the patient's ligaments. However, the source explains a critical trade-off here. The more constrained the implant design, the greater the stress is transmitted directly to the interfaces between the implant, the cement, and the bone. This increases the risk of aseptic loosening without infection, over the long term.
So more built-in stability equals higher loosening risk.
Potentially, yes. It's a biomechanical trade-off. Therefore, more constrained implants like constrained condylar knees, CCK, or rotating hinge designs are generally only used in situations where the patient's own ligaments are severely deficient or absent, which is most common in revision cases, redo surgeries, or sometimes in primary cases with very severe deformities or bone loss.
And the most constrained.
If the joint is very unstable or severely deformed, or if there's massive bone loss, the source says a fully hinged knee replacement may be used. This provides complete mechanical stability through a physical hinge linking the femoral and tibial components, and it does not rely on the patient's ligaments for stability at all. These are typically reserved for complex salvage situations.
Are there ongoing advances in the materials used, particularly the plastic part, to try and make them last even longer?
Absolutely. The source mentions that reducing wear of the polyethylene bearing surface is a major focus, because wear particles are a primary driver of long-term osteolysis and loosening. Modern implants often use enhanced bearing surfaces. Examples given include highly cross-linked polyethylene, which has stronger molecular bonds making it more wear-resistant, vitamin E-enriched polyethylene, where vitamin E is added as an antioxidant to reduce degradation of the plastic over time, or sometimes advanced ceramicized surface coatings on the metal femoral component to make it exceptionally smooth and hard, further reducing friction and wear against the plastic insert.
What are the primary goals of the surgical technique itself when performing a TKR? What is the surgeon aiming to achieve, according to the source?
The source outlines several key technical aims. First, to correct the deformity caused by the arthritis, bringing the leg back into neutral alignment. Second, to leave the leg aligned so the mechanical axis, that hip to ankle weight-bearing line, passes through the center, or perhaps slightly medial, to the center of the knee implant. Third, to ensure the joint line, the level where the new femur component meets the new tibia component, is restored to its correct height and is positioned parallel to the ground when standing.
So getting the alignment right is critical.
Paramount. The source also touches on modern surgical philosophies, mentioning newer techniques that try to match the patient's more individual or kinematic alignment, aiming for a knee that feels more natural, rather than strictly adhering to a generic average mechanical axis. These approaches often utilize enabling technologies like computer navigation or robotic assistance to achieve the necessary precision.
We heard earlier about soft tissue balance being crucial for the native knee. Is it just as important when putting in a TKR?
Absolutely critical. The source emphasizes that it's paramount that the surrounding ligaments, especially the MCL and LCL, and the entire soft tissue envelope around the knee are well aligned and meticulously balanced in terms of tension throughout the range of motion. Proper soft tissue balance is essential for achieving good stability, preventing instability or stiffness, ensuring a functional range of motion, and allowing the patella to track smoothly and correctly in the femoral groove of the implant. If the ligaments are too tight on one side or too loose on the other, it significantly compromises the function and potentially the longevity of the replacement.
What's the typical postoperative course right after a TKR these days? Are people stuck in bed for weeks?
No, definitely not. The source notes that modern protocols emphasize early weight bearing and mobilization. Patients are typically encouraged to get up and start walking, usually with the help of a physical therapist, and walking aids like a walker or crutches, often on the same day as the surgery or the day after. They're also encouraged to start moving their knee early to prevent stiffness. While some centers are exploring outpatient or same-day discharge TKR for selected patients, the source indicates most patients typically stay in the hospital for 2-4 days for pain management, initial physiotherapy, and monitoring before going home or to a rehab facility.
With any major surgery like TKR, there are potential complications. The source lists these in detail, right?
Yes, it's important to be aware of them, even though the overall success rate is high. The source, referencing Table 40.2, breaks them down. Intraoperative complications, things that can happen during the surgery itself, include potential issues like implant malposition or malalignment, which we know can lead to later problems like instability, stiffness, or pain. There's a small risk of nerve or vessel injury near the knee, including potential nerve damage for the tourniquets sometimes used on the thigh during surgery. Fractures of the femur or tibia can occur during bone preparation or implant insertion. Patellar tendon avulsion, where the tendon pulls off the bone, is a serious complication affecting the ability to straighten the leg. And there's a very small risk of fat embolism syndrome.
And postoperative complications, things that can happen after the surgery.
The major, most feared complication is infection, either superficial or deep within the joint, which can be devastating and often requires further major surgery. Other significant risks include blood clots, deep vein thrombosis in the leg veins, and the potentially life-threatening complication of pulmonary embolism, PE, if a clot travels to the lungs. Patients can experience persistent pain or stiffness after surgery, despite a well-done procedure. Instability of the joint can occur if the ligaments weren't properly balanced or if components loosen. Osteolysis, that bone loss triggered by wear particles from the plastic insert, is a common cause of late failure, leading to component loosening, which can be either aseptic without infection or septic if infection causes the loosening. Dislocation of the TKR components is also possible, though rare, particularly with more constrained implants or in complex revision cases.
That's a comprehensive list. Really highlights the potential risks involved, even with such a successful operation overall. And the source provides a summary box reminding us of those key technical goals of TKR surgery: correcting the deformity, aligning to the mechanical axis, getting the joint line perpendicular, achieving balanced ligaments, and ensuring normal patellar tracking.
Those are the fundamental technical objectives surgeons strive for to get a well-functioning, long-lasting, total knee replacement.
Okay. Next, the source covers something called knee arthrodesis. What's that?
Arthrodesis means surgical fusion. So knee arthrodesis is a procedure to permanently fuse the femur and the tibia together across the knee joint, essentially creating one solid bone from thigh to ankle. The knee joint is eliminated, making it completely stiff and non-moving.
That sounds pretty drastic. Is it common?
No, not at all anymore. The source notes it's a rare procedure in modern orthopedics and is largely a historic option. It's seldom considered acceptable to most patients today who understandably value and expect knee mobility.
So it's definitely not used for routine OA treatment. When is it used then?
The source positions it primarily as a salvage option. It's considered in very complex, often dire situations, typically after the failure of multiple previous attempts at knee replacement, especially if those failures involve deep infection that couldn't be eradicated, or if there's massive bone loss, or particularly the crucial extensor mechanism that quad patella tendon unit needed to control a replacement has been severely damaged or is non-functional. In these specific challenging scenarios, achieving a solid, stable, pain-free, fused knee might be the only remaining viable option when another replacement is deemed impossible or unlikely to succeed.
So, end of the line salvage. Does the source mention any situation where it might be used as a primary procedure, the first option?
Yes, but again, only in very rare and specific circumstances. The source mentions it might occasionally be considered as a primary intervention in patients with certain severe neurological abnormalities that would prevent them from having the necessary muscle control to manage and control a mobile knee replacement prosthesis. Examples given include severe paralysis from stroke, conditions like spina bifida or polio affecting leg control, or sometimes in very advanced Charcot-arthropathy, where the joint is grossly unstable and bone quality is extremely poor. Basically, situations where a mobile joint replacement is predicted to fail due to lack of neuromuscular control.
If fusion is performed, is there an ideal position to fuse the knee in? You wouldn't want it fused dead straight, presumably.
No, that's functionally quite awkward. The source specifies the generally accepted ideal position for knee fusion is typically around 7 degrees of valgus, so slightly knock-kneed, and about 15 degrees of flexion, so slightly bent. This position is considered the best functional compromise for walking, allowing the foot to clear the ground more easily, sitting down comfortably, and managing daily tasks with a permanently stiff knee.
And how is the fusion actually achieved surgically? How do they get the bones to knit together?
The source mentions various fixation techniques used to hold the prepared bone ends, femur and tibia, rigidly together while they heal and fuse into one solid bone mass. This can be done using large intramedullary nails, long rods inserted down the hollow center of the femur and tibia, crossing the knee, strong plates and screws applied to the surface of the bones, or sometimes external fixators, large frames applied to the outside of the leg with pins going into the bone above and below the knee. The goal is rigid stability to allow bone healing.
Finally, the source addresses revision knee replacement, the surgery done when a previous TKR has failed.
Right. Although TKR overall has excellent long-term survival, as the source noted, with figures like 82% lasting over 20 years and over 95% lasting 10-15 years, sighted implants do eventually fail in some patients for various reasons, and they need to be revised or redone.
And the timing of the failure often gives important clues about why it failed.
Exactly. The source explains this pattern. Early revision, meaning failure within the first few years after the initial TKR, is most likely due to infection, either acute post-operative or to delayed infection, or sometimes non-infective causes related to the initial surgery or patient factors like instability if ligaments weren't balanced, malalignment, or persistent stiffness.
And later failures, say beyond 10 years.
Failure occurring many years down the line is usually a result of aseptic loosening of the components, meaning they become loose from the bone, but without an active infection being the primary cause.
And what typically causes that late aseptic loosening?
The source points to wear of the polyethylene plastic insert as a primary culprit in many late failures. Over years and millions of cycles of movement, tiny microscopic particles of plastic wear off the bearing surface. These wear particles trigger a biological inflammatory response in the surrounding tissues. This inflammation, in turn, can stimulate cells called osteoclasts to start resorbing or dissolving the bone right next to the implant, a process called polyethylene-induced osteolysis. This gradual bone loss around the implant undermines its fixation, causing it to become loose.
With any failed or painful joint replacement, the source highlights one absolutely critical first step before planning revision surgery.
Yes, this is paramount. The force stresses that infection should always be thoroughly investigated and excluded in any patient presenting with a failed or painful joint replacement.
Why is ruling out infection so critical?
Because the presence of an underlying infection completely changes the required surgical strategy and significantly impacts the chances of success. If infection is present, simply taking out the old components and putting in new ones in a single operation, a one-stage revision, has a high failure rate. Infected revisions often require a complex two-stage procedure. The first stage involves removing all the old implants and infected tissue, placing a temporary antibiotic-loaded spacer, and treating the patient with intravenous antibiotics for several weeks. Only after the infection is confirmed to be eradicated is a second surgery performed weeks or months later to implant the new revision components. Missing an infection and doing a one-stage revision can compromise the outcome, potentially leading to persistent infection and further failures.
How does revision surgery itself compare to performing a primary first-time TKR? Is it similar?
No, the source states clearly that revision arthroplasty is technically more challenging than a primary TKR, often significantly so. The surgeon is frequently dealing with substantial bone loss from osteolysis or removing the old implants, extensive scar tissue, potentially damaged or deficient ligaments, and altered anatomy. Revision surgery typically requires more complex and expensive implants, often using stems that go further down the bone canals for better fixation, metal augments to fill bone defects, or more constrained components. And importantly, revision TKR inherently has a higher complication rate than primary TKR across the board.
Despite those significant challenges, what's the expected outcome? Is it worthwhile?
Yes. The source notes that when revision surgery is performed for the correct indication, like loosening, instability, or after treating infection, and is technically well executed, the results are generally very good in terms of relieving pain and improving function, although the outcomes may not always reach the same high level as a successful primary TKR. The fundamental goal remains the same as with a primary: to provide the patient with a well-aligned, stable, and pain-free knee, restoring function to the best extent possible given the more complex circumstances.
Okay, wow. That was an incredibly detailed journey through the knee joint. We went from the fundamental anatomy, the intricate biomechanics,
The crucial roles of menisci, ligaments, cartilage.
to the whole range of conditions that affect it, from those acute sports injuries right through to chronic, debilitating osteoarthritis.
And then deep into the specifics of the surgical interventions, arthroscopy, ligament reconstructions, osteotomy for realignment.
And the nuances of partial versus total knee replacement, the challenges of revision surgery, and even that rare salvage option of fusion.
We really dug into the details provided by the source material, thinking about things like the significance of meniscal hoop stress for load distribution, that key difference between the anatomical and mechanical axes for alignment,
The biomechanical genius of the patella, and those incredible forces it handles.
the critical difference in healing potential between cartilage and other tissues, which drives so many treatment strategies.
The pros and cons comparing partial and total replacements, understanding why one might be chosen over the other, and why revision rates differ.
And just appreciating the complexity involved in fixing things when they go wrong, especially in revision situations.
By going this deep into these specifics, really grasping why the knee is inherently unstable, how the menisci work to spread load, why correcting alignment is so vital biomechanically, how different ligament bundles contribute, understanding the limitations of cartilage repair, and the challenges of implant wear and loosening, you, the listener, have hopefully gained a level of foundational knowledge that goes way beyond just a basic overview.
Yeah, it's the kind of detailed insight that professionals in this field really build their understanding and practice upon. It's about seeing how form, function, pathology, and treatment are all completely interconnected in this vital joint.
Exactly. And thinking about the major challenges we've discussed throughout this deep dive, particularly the inherent difficulty in getting damaged articular cartilage to truly heal itself, the significant functional consequences of losing meniscal tissue, and the ongoing issues of wear and tear limiting the lifespan of current implant materials like polyethylene, it leaves us with a fascinating question to ponder, one that builds directly on everything we've learned from the source. Given the continuous advancements we see in biomechanical research, material science, and biological understanding, how might future solutions finally overcome some of these fundamental limitations? Could we, for instance, realistically expect breakthroughs in regenerative medicine that allow us to reliably regrow fully functional hyaline cartilage or even meniscal tissue within the joint? Or perhaps could new generations of biomaterials be developed for joint replacement implants that essentially eliminate wear altogether, potentially making them last a lifetime and dramatically reducing the need for those complex and costly revision surgeries?
Those are exactly the kinds of questions driving the cutting edge of research in orthopedics and bioengineering today. They stem directly from trying to solve the persistent challenges highlighted in detailed texts like the one we've explored. It's about pushing the boundaries based on this deep understanding of the current state of the art.
A truly thought provoking frontier, building right on this solid foundation we've explored. Thank you so much for joining us on this deep dive into the complexities of the knee joint.
It was a pleasure. Keep thinking critically about the amazing complexity inside us and the incredible efforts humans make to understand and repair it.